Welcome to Country. Here in Kyneton, Victoria, our Welcome to Country acknowledges the traditional custodians of the land, as the region is a significant part of the broader area managed by three clans, the Taungurung, Dja Dja Wurrung, Wari Wurrung, the Wurundjeri people. Welcome to this presentation. Today's focus is on implementing recovery-orientated practice under the umbrella of effective trauma-informed care practice, TICP. Focusing on the trauma group of sexually abused children and adolescents, identifying the barriers related to successful trauma-informed recovery-orientated practice outcomes. The key aspects will be detailed evidence-based recommendations of practices to support changes in organisational culture, policy and procedure, and professional practice, why these outlined recommended changes are needed, and how they will be designed to improve recovery-orientated practice. All key aspects will be summarised and concluded. Trauma of all kinds affects every aspect of a victim's life. That includes personal and family relationships and functionality in society and workplaces. The effects to the physical body and mental health are extensive and can be obviously apparent and expressed to different degrees depending on underlying condition, such as severity and length of time to which they are exposed, and age and mental state at the time of exposure. All of which affects if, how, why, and when a victim may find help, and how that trauma-informed care can be implemented successfully. The barriers for implementing recovery-orientated practice are individually based and complex. Traumatic events can trigger our fight or flight response, releasing cortisol and adrenaline. And with prolonged exposure, traumatic events result in maladaptive coping mechanisms that, without trauma care intervention, can lead to long-term post-traumatic stress disorder, PTSD. Childhood trauma events can be classified by 10 areas, each scored as 1 ACE, or adverse childhood experience, with 3 major categories: neglect, abuse, and household. Patients with chronic abuse to trauma can present with high or low levels of stress hormones, cortisol and adrenaline, and these can have a negative effect by either raising their heart rate and associated blood pressure, or can present as dissociated if levels are low. Adolescence trauma expression is a complex of emotions and behavioural distress. Covert symptoms are acted out, including aggression, vagueness, eating disorders, avoidance of people, general detachment. Conversely, somatic and withdrawal symptoms are signs of internalised mental and physical symptoms. Adolescents hide emotion as a survival mechanism to avoid attention or stigma. This is known as masked expression, to internalise behavioural changes. Masking, rebellious, defiant, aggressive, to hide their real fears. Substance abuse or risky behaviour, reckless activities including sexual. Social masking, pretending to be happy and smiling when hopeless or depressed. Over-independence is the need for self-sufficiency and control. Psychological barriers attributed to lack of disclosure. Fear of not being believed or retribution by the perpetrator. Shame, blaming themselves. Inability to recognise actions as wrong. Not able to express due to language. And underlying deep psychological pain. Symptoms. Life trauma affects the neurochemical production and affects the blood-brain function. Cortisol levels and affecting social behaviour, fear of learning, stress-related responses. Physically and mentally, the psychological presentation of sexually traumatised adolescents include intrusive thoughts, inappropriate negative memories, flashbacks, body distortion ideas, and including a desire to make oneself less attractive to avoid attention. Somatic symptoms are physical symptoms like headaches, muscle aches, and stomach pain. Cognitively, feelings of shame and guilt are also inhibitory barriers to accessing help, with anxiety, depression, and suicidality attributed to 40% of mental health issues in adolescence. Socially, the ability to trust is the critical bond that is lost with most relationships. Clinically, the ramifications of these deep physical and mental barriers are adaptive survival mechanisms are critical for these trauma-informed models to essentially understand that these presentations are learned and are maladaptive actions requiring sensitive addressing to relearn trauma-conditioned responses for a healthy long-term sustainable recovery approach by implementing TIPC. Recommendations. Organisational cultural changes. Fostering a safe culture is a key measure that can be welcomed and achieved by encouraging open feedback that is valued and actioned. Accommodating the successful underpinning of trauma-informed care by implementing recommended recovery practices. Embracing the 6 core principles of safety, peer support, collaboration, trustworthiness, empowerment, and gender cultural responsiveness in the centre. Encompassing global understanding and acknowledgement. Staff personal training complexities are understood and skills can be learned to assist and eliminate further trauma. Active leadership to collaboratively focus on individual workplace trauma needs and integrate victims' presentations and symptoms rather than historical events that may re-traumatise. To foster ongoing collaboration within internal teams and external services to broaden the knowledge and transfer of information on successes will increase the reach for long-term sustainable health. Policies and procedures can be changed to augment the personal development of staff and embedding TICP into organisational practices, illustrating the principles around trauma-informed care and the steps that will be observed to align policy and procedures can be measured for further reference with the intent to ensure policies are followed. Practices can be written into policy to create a standard of care, like the E-Safety Commission talking about sexual abuse of adolescents online. All augmented TICP treatments that increase emotional engagement are included into policies such as cognitive behavioural therapy for post-traumatic stress, for legal acknowledgement and coverage in the future. In practice, all of these changes that have been identified at an organisational level, plus those included in policy and procedures, can then all be referenced and utilised, including a data bank of successful results and outcomes. By focusing on individual presentations and addressing each physical or mental symptom using realise, recognise, respond, and resist re-traumatisation, the prognosis of a healthier and functional future is possible. As a result of childhood trauma, anger can present as an initial reaction and response to the hormonal rush of adrenaline and cortisol in the natural fight or flight reaction that is heightened and a triggered reaction to long-term exposure to trauma. Other behavioural presentations such as substance abuse, risky behaviour, criminal activity, and 1/3 will have a mental disorder, including depression, anxiety, an eating disorder, and suicidal ideation. Physically, results prove high rates of mental ill health, chronic disease, substance abuse, and early death. Victims of trauma are 15% more likely to have a form of severe chronic disease compared to a person without trauma exposure. This includes autoimmune, heart disease, and obesity. Victims of traumatic events are twice as likely to develop cancer. These expressions are maladjusted coping mechanisms to deflect and protect, but with prolonged exposure to trauma, these conditions become a learned response and become a conditioned subconscious reaction to confrontations. Severe sexual childhood trauma is correlated with the expression of anger and alcohol abuse in adulthood. A foundational study by Folletti in 1998 identified 2 key outcomes. Childhood trauma exposure is pervasive, meaning its negative effects impact all aspects of a victim's life functionality in social relationships and workplace settings. It has been shown that it takes on average of 23.9 years for survivors of child sexual abuse to tell someone. Trauma-informed practices are needed to be embedded into organisations' policies and practices because this victim-centred approach is implicated for long-term success to dramatically improve sustainable results for a functional life and reduce costs with other less responsive therapies. The TIPC model improved psychological, physical and behavioural global presentations benefiting the individual and surrounding community. This evidence highlights the imperative need for a successful treatment model of care implementation, providing the eminent need for recovery-orientated trauma-informed practices to support the long-term psychological and behavioural needs of victims and reduce the cost of ineffective secondary treatments. In conclusion, trauma-informed care is an essential path to long-term treatment for all debilitating behavioural, psychological and physical trauma presentations, and for adolescents with sexual abuse symptoms, by addressing conditioned maladaptive coping strategies that cultivate normal functioning. TICP is particularly effective with victim-centred approaches, preventing re-traumatisation, building trust and open communication, and increasing understanding, leading to better outcomes by way of accepting treatment of core principles and processes. Evidence-based practice has proven trauma-informed, recovery-orientated care is the most effective model for long-term outcomes for trauma symptoms, presentation and treatment. Incorporating TICP into organisations' policy and procedures and in professional practice produces the best standard of care, resulting in higher rates of sustained life functioning across all parameters of relationships, social, workplace, personal well-being. At a cost of $24 billion per year, preventing trauma by education and collaboration by trauma-informed care, practitioners and communities can become more responsibly aware and work together towards a recovery-orientated practice in our society. Thank you.